Hello, we'll be discussing mycobacterial skin infections today. And mycobacteria can cause two types of skin infections. One is tuberculosis, the other is leprosy. And we'll be discussing tuberculosis in this section. So cutaneous tuberculosis is classified on the basis of where the bacteria is coming from. So either it's coming from an exogenous source or an endogenous source. And we'll also be discussing about tuberculates. So if the bacteria is coming from an exogenous source, then we divide the bacteria, we divide the cutaneous classification on the basis of whether the immunity is high or whether the host immunity is low. So how would the host immunity be high? So the host immunity would be high if there is a previous exposure to tuberculosis. But if there has not been any previous exposure to TB or the host is a naive host, then the immunity would be low. Okay, so if the immunity is high, then the manifestation would be in the form of TBVC, which is tuberculosis verrucosa cutis. And if the immunity is low, so it's a naive host, then it would be TB Shanker. Okay. If the bacteria is coming from an internal source, so from the host in itself, then how would it manifest? So if the bacteria is coming from the blood, so hematogenous source, it will cause either lupus vulgaris, miliary TB, or TB gamma. Okay, so now what can be the other sources of infection? So the other sources of infection could be contiguous spread, which means that there is already a source of infection underneath the skin and this has now just burst into the skin. We'll read more about it. So it's known as scrofuloderma. And the last one is autoinoculation. So the source is already present in the host and the host itself is autoinoculating this bacteria onto the skin. So autoinoculation. And it will cause orificial TB. So now a question arises, which is the most common type of TB? So the most common type in adults is lupus vulgaris. And the most common type of TB, cutaneous TB, is also lupus vulgaris. Okay, so most common in adults and overall it's lupus vulgaris, but the most common in children. So if the question asks you in children, then it's scrofuloderma. Okay, now an important point to note is if the host immunity is high, then it will act against the bacteria, it will try to destroy the bacteria, and the manifestation would be a paucibacillary type. Of infection. But if the immunity is low, then the manifestation would be multibacillary. There will be multiple bacilli just because the host is not able to destroy these bacteria. Okay. So we'll be discussing next one is TB Shanker. So most of the times the TB bacilli would infect lungs. So the first organ to be affected in humans by the TB bacilli would be lungs, and the first source of infection can cause something known as Gons focus. We all know about this. So this is primary TB in lung. So what happens is if the host is naive, as I just told you, the naive host has low immunity. And if the exposure of tuberculosis is for the first time, it will cause TB Shanker. And this is analogous to Cohn's focus of lungs. Okay. So what is the manifestation of TB Shanker? So the TB Shanker would manifest in the form of an ulcer with undermined edges. So undermined edges means this. So depressed towards inside. Okay. It will have a bluish border. So if you see this, so the undermined edges and a bluish border. Okay, so ulcer will have a bluish border. So now, what are the other causes of undermined ulcer that you see in dermatology? So undermined ulcers can be seen in chancroid. It can also be seen in pyoderma gangrenosum. So TB Shanker is also known as primary skin TB. Okay, because it is the first site of infection in the skin in a naive host. Okay, and it is analogous to Cohn's focus. So next we'll be discussing tuberculosis verrucosa cutis. As the name suggests, tuberculosis verrucosa cutis. So what does the name suggest? It's TB of the skin and it has a verrucous or a warty surface. It is also known as anatomist wart and it is commonly seen in anatomists, pathologists and farmers. And why it is seen in them? Because these are the people, anatomists and pathologists, who handle human tissue. And if human tissue is infected with tuberculosis, they'll also get this. And this happens through inoculation. So that's why it is known as anatomist wart. Okay. So anatomist, pathologist and farmers. And where would these lesions occur? So all the areas which are exposed, so hands and feet, and the trauma prone areas, so hands and feet, they would be the areas that will be affected by TBVC or tuberculosis verrucosa cutis. It's abbreviated as TBVC. So now, as we just discussed, that TBVC will be caused in hosts which will have high immunity. Okay, and if the host has high immunity, this would be a paucibacillary type. Okay, so now how does the lesion look like? So it's a well-defined warty plaque. Okay, well-defined warty plaque with a rough surface, and there can be areas of scarring in it, or it can heal with the scarring, and there may be some discharge, some serous discharge as well. And what would be the histopathology findings? So if you take a biopsy, what will you find on histopathology? You all know histopathology of tuberculosis is that you will find granulomas. So you will find tuberculoid granulomas in this. Okay. So now, whenever you think about warty surface, then what comes into your mind? The first thing that will come to your mind would be a wart, a viral wart. Okay, so how would you differentiate it between a viral wart and TBVC? First of all, this would be a single lesion. This would be there would be multiple lesions. See, if something is big enough to cause this, and if it's a viral wart, it will spread because it has a lot of phenomenon of pseudocochlearization, and it will spread. But if there is a single plaque with verrucous surface, then it is likely that it is TBVC, at least in Indian context. Okay, and TBVC will have scarring. There will be no scarring. It will have other signs of inflammation like induration, and we discussed discharge. This would be absent in this. Okay. Next, we'll be discussing lupus vulgaris. So, lupus vulgaris most commonly occurs due to an endogenous cause. We discussed that it is through hematogenous spread. Okay, there can be an exogenous cause as well. Suppose a person sits on sputum in a farm which is infected with tubercular bacteria, they will cause exogenous type of lupus vulgaris. Okay, but the most common type is the endogenous type. So more than 50% of the manifestations of lupus vulgaris would be due to endogenous cause. So now it is, as we discussed, most common type of TB in adults and in India. Okay, and it is found in hosts which have high immunity. And as we discussed, if the patient has high immunity or the host has high immunity, the manifestation would be possibacillary type. So less AFPs. Okay, and what would be the common site? So what would be the common site of lupus vulgaris? So common site would be buttock. As I just explained, if someone sits on sputum, it will infect the buttock and it is the commonest site. So buttock would be the commonest site, followed by lower limbs, another site where inoculation can happen. So these are the most common site. And how will the manifestation occur? So the manifestation would be a plaque. So as you can see, this is a plaque. It is a well-defined plaque with bluish or violaceous margins. You can see this is a violaceous plaque with bluish margins with an active edge. So plaque with active edge and central scarring. So this is central scarring. You can see this scarring. Okay, hence, because it's a plaque, it is also known as plaque type lupus vulgaris. Okay, so now many times question comes on these aspects. So this, as we just discussed, is central scarring. Central clearing is seen in tinea infections, okay, which is a fungal infection, and central crusting is seen in leishmaniasis. Okay, so these are the questions that are asked, commonly asked. Okay, central scarring, clearing, and crusting. So now this is a bedside test known as dioscopy test, which is used to diagnose this condition. Okay, so what is a dioscopy test? So if you take a glass slide and we press the lesion with a glass slide, so what will happen is erythema will disappear. Okay, so the lesion will blanch and you will see these small golden yellow nodules. These are known as apple jelly nodules. Okay, because they are golden yellow in color, so they are of color of apple juice or golden yellow nodules. So these are known as apple jelly nodules. So this is a question. This is frequently asked. It's a dioscopy is a bedside test. We'll discuss it in our basics. So the next infection is scrofuloderma. So as we discussed, scrofuloderma occurs due to contiguous spread. Okay, so how does a contiguous spread occur? So that means there is an underlying source of tuberculosis and now this source is just burst on the skin. Okay, so what can these sources be? So the source could be either a bone, or it can be lymph node, or it can be a joint. So this is a bone. Okay, there is tuberculosis bacteria. So there's probably tubercular osteomyelitis, and the skin overlying it bursts here and it forms a condition known as scrofuloderma. This is the neck, you can see. So here cervical lymph nodes are present. So when these cervical lymph nodes increase in size and they bulge on the skin, they form a scrofuloderma. Okay. Similarly, in joints as well, this happens. Okay. Scrofuloderma commonly occurs in hosts which have low immunity. And why the immunity is low? Due to either malnutrition or other immunosuppressive states. Okay. And because the immunity is low, it's a multibacillary type of tuberculosis. Okay. So the clinical features are that you'll see multiple discharging sinuses. Okay, so there will be multiple discharging sinuses that will occur on the skin, and they will discharge pus which will contain lots and lots of acid fast bacilli, because it's a multibacillary condition. Okay, and because the immunity is low, it is very commonly manifested in children which have low immunity. So it's very common in children. Okay, and when these sinuses are present on the skin, they are surrounded by bluish or violaceous margins. So it is the most common type of TB in children in India, because children have low immunity. Okay, and when they are affected with malnutrition, this whole process accelerates and this condition occurs. Okay, next infection is orificial TB. What do we mean by orificial TB? So we have two orifices on our body. And what are these two orifices? We have our mouth and we have our anus. So if tuberculosis occurs around the skin of the mouth or the anus, it is known as orificial TB. So now orificial TB is caused in hosts which have low immunity. So if the host has low immunity, then it would be a multibacillary. Now you know. Okay. So if a patient has pulmonary coughs and he coughs sputum, okay, this will auto-inoculate. As we discussed before, this is a type of auto-inoculation. So the host will auto-inoculate its own skin with an infection that he or she already has. Okay. So cough and then auto-inoculation. And if a patient has GI TB or GI coughs and the patient defecates, okay, then again auto-inoculation will occur. Okay. So now next we'll read about tuberculates. So tuberculates. So what does it means? It means daughter. And tuberculosis is not the only manifestation or the only infection that causes AIDS reaction. AIDS reactions are caused by HIV. They are also caused by fungal infections. Okay. So what is a tuberculate? So tuberculate is defined as when the CMI of the host is high, that is the tuberculin test or the MON2 test, or is positive. Okay, so MON2 test or tuberculin test is the manifestation of the host immunity, so that's high. There is culture negative. That is, there are no acid fast bacilli on the culture, but the patient responds to ATT. So, in any condition, if the patient is respond to ATT, which is anti-tubercular treatment, that means there should be some infection somewhere. But when we culture or when we biopsy, there is no AFP, so it's culture negative. Okay. But there is still some hypersensitivity present, and that's why CMI is positive, and that's why tuberculin test or Montus test is positive. And why would that be? So tuberculin test and Montus test are positive. There is negative culture, but the patient is still responding to treatment. Why is that? Because there might be some focus elsewhere. And that's why it is causing this mycobacterial hypersensitivity. Okay, so tuberculosis, mycobacterial hypersensitivity reaction to focus of tuberculosis elsewhere on the body. Clear to everyone? So now, what's the classification of tuberculosis? So tuberculosis are classified as true tuberculosis, facultative tuberculosis, and false tuberculosis. So true tuberculosis are the manifestations of tuberculosis which are only found in tuberculosis. Facultative can be found in other conditions as well, and false is not a tuberculate at all. Okay, so what are the examples of true tuberculosis? It can be micronodular, papular, or nodular. So micronodular is lichen scrofulorum. Nodular is erythema induratum of Bazin, and papular is papular necrotic tuberculate. We'll be discussing about all these. Then facultative is erythema nodosum. Why it is facultative? Because tuberculosis is not the only cause of erythema nodosum. There can be other cause like drugs, other infections. And then false is lupus, miliaris, disseminata, fasciae. We'll read about them, okay? So lichen scrofulorum. So first of all, the most important thing is it is not a type of lichen planus. So okay, so it's not a type of lichen planus. But then why it is known as lichen scrofulorum? So that's because of the clinical features of this condition. So they are small lichenoid. There are small lichenoid papules present in a grouped manner in perifollicular distribution. Okay, you can see these small lesions. So these are all in perifollicular distribution, present in the form of plaques, and they are lichenoid in characteristic. Okay, this is a micronodular type of tuberculate, and the most common patient is a child. So most commonly found in children and found on trunk. Okay, so if you do a skin biopsy, then what do you see? You see perifollicular and periappendageal. What will you see? Granuloma. So it's a TB type of TB. It's a tuberculate. So you'll see granulomas. But because it's a tuberculate and not a true TB manifestation, it will have absent acid-fast bacilli. So absent acid-fast bacilli, but there would be granulomas which would be present in perifollicular and periappendageal manner. Okay, and this is a question that was recently asked. So moving on to next tuberculate is papillonecrotic tuberculate. Now, what do you decipher from the name? So papules, necrotic, and tuberculate. So there are necrotic papules present in a tuberculate. Okay, so it's most commonly seen. Lichen scrofuloderma was seen in children. This is seen in adults. So there will be multiple papules with central necrosis and ulceration. Okay, so papules with necrosis and ulceration, and these are commonly present on extremities. And in this condition, patient is quite sick. Okay, so patient is unwell, and because there's so much necrosis, there's so much ulceration, these lesions will heal with scarring. And again, what will we find on histopathology? We'll again find granulomas, but all this necrosis will cause caseous necrosis, and hence we'll find caseating granulomas. Okay, and how will you treat this condition? This condition responds to anti-tubercular treatment. So this condition responds to anti-tubercular treatment. So next two type of tuberculate may resemble each other. So that's why we'll discuss them together. So it's erythema induratum of Bazin and erythema nodosum. So this is also a nodular type of tuberculate, and erythema nodosum is also nodular type. So what's the main difference? So the main difference is lies on the site. So erythema induratum of Bazin is seen on calves, and erythema nodosum is seen on shins. Okay, also the lesions in erythema induratum show tendency to ulcerate. So these show tendency to ulcerate, and hence they leave scarring. Okay, so they ulcerate and leave scarring, but erythema nodosum never ulcerate. Okay, and they never leave scarring. So both these types, erythema induratum and erythema nodosum, are a type of panicleitis. But histopathologically, these two are panicleitis, but this is predominantly a lobular panicleitis, whereas this is a predominantly septal panicleitis. So you see, this is our skin, this is the subcutaneous fat tissue. Okay, so these are the lobules and these are the septa in between. Okay, so if inflammation affect these lobules, then it's lobular panicleitis. If it affects the septae, it is known as septal panicleitis. Okay, so moving on to the false tuberculate. So false tuberculate are also known as LMDF. So types of false tuberculate: LMDF, which is lupus miliaris disseminata fasciae. Okay, they're also known as figure. So lupus miliaris disseminata fasciae, or also known as figure. Figure is an abbreviation for facial idiopathic granulomas with regressive evolution. Okay, so previously this condition was also thought to be a true tuberculate, but subsequently we realized that this is not related to tuberculosis. This is due to some other causes, but it's still but we still read it just so that we know the difference. Also, these lesions are commonly present on your mid face. And what are the lesions like? These are small skin colored lesions present over the mid-face. Okay, they can also be present around eyes, and histopathologically they also show granulomas, periappendageal granulomas, and that's why previously they were thought to be related to tuberculosis, but now no longer. They are considered to be a part of tuberculate. Okay, so they show periappendageal granulomas. So now we have read all these types of cutaneous tuberculosis. But what's the treatment of cutaneous tuberculosis? So under revised national guidelines of 2017, cutaneous tuberculosis is now classified as category 1. Okay. So RNTCP 2017 shows that skin TB should be given category 1 treatment. Okay, so what is category 1 treatment? It's 2 months of intensive phase and 4 months of continuous phase. And what do you give in 2 months of intensive phase? You give HERS, which is isoniazid, ethambutol, rifampicin, and pyrazinamide. And what do you give in 4 months of continuous phase? In 4 months of continuous phase, you give HER, isoniazid, ethambutol, and rifampicin. Okay, so many of the time people get confused amongst the dosage. So daily dosage according to body weight is 5, 10, 15, 15, 25. So 5 for isoniazid, R for rifampicin, 10. Then ethambutol has 15, then streptomycin 15, and pyrazinamide 25. So 25 milligram per kg. So all these dosages are milligram per kg per day. So this finishes cutaneous tuberculosis. Thank you.